And we're going to be talking about managing co-occurring alcohol use disorder. I'm going to try to keep to the time, so I may rush through a few of these slides. And I realize there were some question slides, and that since we're recording, people can't answer those, so I'll kind of just glaze over a few of those slides. And so a lot of our folks who are on buprenorphine, for instance, also will have alcohol use disorder, but this presentation also, it will be for folks who that is their sole use disorder. So the objectives are to learn the signs and symptoms of alcohol withdrawal syndrome, learn ways to properly manage withdrawal. I'll also say we're going to talk briefly about screening for for alcohol use disorder, and also to become familiar with FDA-approved medications and some few of the psychosocial interventions for treatment. So this is a case just to kind of get us started. Your patient is Ms. A. She's a 41-year-old female with a history of hypertension and opioid use disorder, presenting to clinic for routine follow-up on her blood pressure. She's been taking her buprenorphine, her hydrochlorothiazide, or lisinopril, and she tries to follow low-sodium diet and exercise. She quit smoking tobacco 2 years ago, but she does report daily alcohol use, and on physical exam, her blood pressure is 154/98. And the rest of her exam is normal. So while seeing her, you're concerned that her blood pressure could be uncontrolled due to her alcohol use, or at least related to it. And how do we determine if she has a pattern of risky drinking or if she actually has an alcohol use disorder? So it's good to be familiar with standard drinks because someone may say, I have 3 drinks a day, but it's actually more than that based on the size. And so in the US, you can see here the 12-ounce beers. One counts as 1 standard drink, 5 ounces of table wine. For instance, the spirits, you can see the typical amounts. And so it's good to quantify, do you mean a 12-ounce? Do you mean more than that when you're talking about having 3 or 4 beers a day? And what is risky drinking? So the National Institute on Alcohol Abuse and Alcoholism defines these quantities as low risk for developing alcohol use disorder for adults who are not pregnant if they meet the following amounts. So for women, women shouldn't have more than 3 drinks in one day and no more than 7 drinks in 1 week. So for instance, if she's having 2 drinks every day, then that's more than the 7 drinks in 1 week. So it would qualify by one or the other. And for men, no more than 4 drinks in one day and no more than 14 in 1 week. And the NIH has good patient tools as well that are nice sort of visuals that you can use in your clinics to help patients kind of identify and answer these amounts. And just briefly to touch upon our DSM-V diagnosis of alcohol use disorder, you can kind of glance through these, but essentially these are looking at recurrent drinking that's resulting in failure to fulfill their work or interpersonal obligations, drinking in hazardous situations, physical evidence of tolerance, so drinking more to get to the same amount, or withdrawal when they stop drinking, trying to quit but not being able to over time, spending a lot of time recovering from alcohol use or obtaining the alcohol, and craving, importantly, is also one of the DSM-V criteria for alcohol use disorder. So again, this is the pop quiz, which I won't have you answer here, but the question is, what percentage of people with alcohol use disorder in the US are prescribed one of the 4 FDA-approved medications? And you can kind of look over there and think what you think it might be. The answer is actually A, so less than 9%. So talk briefly about treatment rates. Only about 6.5% of adults and 5% of youth with alcohol use disorder in the past year in our country received treatment. Less than 1 in 10 people in the US with a diagnosis of alcohol use disorder received treatment of any kind in the last year. And treatment is primarily counseling and referral to groups. So over 90% of community programs, excluding VA programs, this is the principal treatment. So again, not involving necessarily the types of behavioral interventions that we'll bring up later or medications. So quite low treatment rates. So SBIRT is a very effective model, so screening and brief intervention and referral to treatment that has good evidence, especially in primary care settings. USPSTF gives us a grade B recommendation for screening for alcohol use in adults, and providing the brief counseling intervention for those who are engaged in risky or hazardous drinking. The evidence is strongest in primary care, but it can be administered in many different settings and by a variety of healthcare professionals. It involves the 5 A's approach that you've probably also seen with tobacco use. So ask about use, advise to quit or decrease, assess their interest in this, assist them if they are interested, and arrange follow-up for treatment. The sessions can be very brief and can last anywhere from 5 to 20 minutes. Because it has a grade B recommendation, it is covered by Medicaid and Medicare. And the goal is to reduce the risk of negative consequences of use, which that may sound familiar. That's also the goal of harm reduction, right, is to reduce the negative consequence of one's use. So not necessarily abstinence, but that may also be someone's personal goal. So for screening for risky drinking and alcohol use disorder, you can start with a single question approach about heavy drinking. And that from NIH is, how many times in the past year have you had 5 for men or 4 for women or more drinks in a day? And you see that's right above the cutoff of what their definition is for low risk drinking. If they answer positive, then you would follow through with assessing the severity of their risk using a validated method such as the audit or audit C. In adolescence, it's also important to screen. This data is startling. 1/3 of children have had alcohol by the end of 8th grade, and 1/2 of those children reported heavy drinking. We don't have sufficient evidence yet from USPSTF, although I think that is under review still, for screening for alcohol use disorder in adolescents, but both NIAA and the American Academy of Pediatrics recommend routine screening for children between the ages of 9 and 18. That's a website there at the bottom of the slide that has some good guides that can be used in the clinical setting. I'm sorry, I'm kind of going quick, so I'm going to leave time for Amy's talk. CRAFT is the adolescent screen that's been validated, and this is important, especially in younger children, to avoid ambiguity. So you can also consider a lead-in to kind of acclimate them to the question in a way about their friends' use. But when you're asking them about their use, something very direct, such as during the past 12 months, did you drink any alcohol? And any positive answer should then be asked with, and this is what the CRAFT stands for. So have you ever ridden in a car driven by someone who's using? Do you ever use alcohol? This model is also for other drugs, to relax. Do you ever use alcohol or drugs alone? Do you ever forget things while you're using? Have your family or friends told you to cut down? And have you gotten into trouble while using alcohol or drugs? So back to your patient, Ms. A, she does respond yes to your single question screen. So you administer the audit C, which we'll look at here in a minute, and she scores a 7, which is positive. And upon further discussion, you learn that she is quite afraid of stopping her use because she had withdrawal, sorry, there's an S there, 2 years ago, that resolved with return to alcohol. So she did not receive treatment. It's interfering with her home life, and she asks for your help. So this is the audit C, which is the shortened validated version also of the audit questionnaire. And you can see that she scored a 7 based upon that she drinks 4 or more times in a week. On a typical day, she has 3 or 4. And and then for number 3, how often do you have 6 or more drinks on one occasion? That's monthly. So she got a 2 for that. So turning to treatment, what can you offer? So here we're going to talk about both the acute withdrawal, figuring kind of how to address that with her, and then ongoing treatment and management of her use disorder. So the first thing is to decide if she is appropriate for outpatient versus inpatient management of her withdrawal. So if she is presenting to you in withdrawal, This is the first thing to assess. Inpatient's necessary in about 1 out of 5 cases. However, I know in our community it can be quite difficult for people to access inpatient treatment, especially if, as in her case, she's also on the buprenorphine. She may or may not receive that inpatient. But it is indicated if there's a prior history of seizures or delirium tremens, if someone has a history of a TBI, if they're pregnant, if they have significantly uncontrolled comorbidities, such as severe hypertension, if there's a lack of support at home to help with the detoxification process there. And then you also need to, in the emergency setting, assess the ABCs, provide, emergent or supportive care, and also in the terms of assessing for mental status change, where Wernicke-Korsakoff syndrome becomes a potential threat, you provide IV thiamine and glucose. And withdrawal symptoms typically present early on, so 6 to 24 hours after the last drink is when they're at highest risk for needing hospitalization, perhaps if there's a risk of seizure. DTs can be a little bit longer after their last drink. Early symptoms to look out for are anxiety, nausea, headache. On physical exam, you might see increased heart rate, blood pressure, sweating, tremor. And again, seizures usually begin earlier, about 8 to 24 hours after their last drink, and DTs usually begin a little bit later on, so 3 to 4 days potentially after. And the CIWA scale, which is the Clinical Institute Withdrawal Assessment, is what we use to help us determine the severity, because a higher scale would make us more likely to send someone to inpatient or to the emergency room. So this is hard to read here, but I did want to include a CIWA scale for you. If you're not familiar with one, it is helpful just to glance over and kind of understand the criteria that contribute to the score. It's a mix of subjective and objective. So some of what the patient's reporting, nausea, visual disturbances, tactile disturbances, auditory, headache. Some of it is what you're observing, so the sweats and agitation, tremor. And then at the bottom there you can see their cumulative score in terms of just determining what they need in terms of medication and in terms of a clinical setting for treatment. And we use this in our clinic, and it's also used in the inpatient settings. So back to your patient, you assess her further, administer the CIWA, and she scores a 12. So she is definitely exhibiting signs of withdrawal. However, she's not in that severe range where we would necessarily be transporting her, let's say, to the emergency room. She does not have a history of a head injury or seizure, and she's not pregnant. She does have support at home. So she actually prefers and is a good candidate for outpatient detox. And this is one example from the AFP. There are others of an outpatient detox regimen. The Librium, I know that our inpatient service uses. We tend not to use it at ASAP so much because of the risk of folks with liver disease not processing it, and it kind of can cloud them. And so we tend to use lorazepam or oxazepam down at the bottom because those are not processed by the liver, and so if someone has cirrhosis, it would be safe to use those. But these are medications that we will give for someone to take typically on the first day every 6 hours, and then hold if there's any sedation. So there's a take as needed method and then a scheduled method that these can be administered in. And then we taper these over 5 to 7 days. We will typically see people, if possible, daily in our clinic, but prescriptions certainly in some settings where it's not possible to be seen daily, can be given for the 5 to 7 days with instructions, especially if you feel like your patient is willing and able to be able to follow those instructions on how to safely take an outpatient taper. Okay, and then another pop quiz: which of the following medications used to treat alcohol withdrawal should be avoided in liver disease? And the way to help remember this is LOT, L-O-T there. The last 3 on the list are okay in liver disease, but we try to avoid the Librium or chlordiazepoxide there at the top. Okay, so your patient returns after a successful taper at home, but she's having very strong urges to drink. So what medications can you offer? So we're going to go through the evidence for the FDA-approved treatment for alcohol use disorder. And our strongest evidence is for naltrexone and then long-acting naltrexone, the intramuscular injection, also known as Vivitrol, and Acamprosate. And then Disulfiram or antabuse is also approved, however, doesn't have the same level of evidence. But we'll start with that. So disulfiram works by inhibiting aldehyde dehydrogenase and creates this disulfiram ethanol reaction, which is very uncomfortable for people. The signs of this include flushing, fast heart rate or palpitations, nausea, sweating, shortness of breath, confusion. If someone does seem to be a good candidate for disulfiram, and I'll say, I don't think I have this on this slide, but typically these are folks who can take it under, it is there on the last bullet there, can take this under direct supervision. So for instance, at our clinic, and folks who are coming to the methadone window, we sometimes will dispense it there. Other settings are like perhaps where they have a supportive environment at home, and they may have a partner who's going to be also helping them take their medications. This does require some monitoring of liver function. It is contraindicated in heart disease. The daily dose is usually 250 milligrams a day up to 500 milligrams. And it's contraindicated if someone doesn't have a goal of complete abstinence, again, because of that reaction with alcohol. So again, there's not really good trials that support its efficacy, but it's probably best when it's taken under supervision. So the next medication is Acamprosate, and this is an amino acid derivative. It works in different ways, probably most by increasing GABA transmission. It's thought to stabilize the glutamate receptor, and so also helps in terms of alleviating some of the physical symptoms of alcohol withdrawal and craving. The daily dose is a little bit difficult to take because it's supposed to be given 3 times a day and 2 pills 3 times a day for that total of 666 milligrams. For folks who have a hard time with that dosing regimen, it can be split in that total dose could be split into twice daily dosing. But it's not metabolized by the liver, so this is the key with this one. So for people who have contraindications to naltrexone or perhaps disulfiram due to liver disease, they can take this one. They do need baseline kidney function. And there's a fair amount of evidence. Most of the evidence, I believe, actually comes out of European trials. A Cochrane review of 24 trials involving nearly 7,000 patients did show Acamprosate decreased relapse to alcohol when compared with placebo with a number needed to treat of 9. And it seems to be most important in preventing a relapse in someone who's already stopped alcohol, so has been off of it for about 1 to 2 weeks. But it is not contraindicated in someone who is still recently or drinking. So naltrexone is our opioid antagonist, which is also FDA approved for opioid use disorder, first in 1984, and then for alcohol use disorder a decade later. It is thought to help by blocking the effects of endogenous opioids that are released from alcohol consumption, so kind of blunting that reward. Its FDA-approved daily dose is 50 milligrams. The long-acting naltrexone, otherwise known as Vivitrol, is a monthly dose. There is a method called the Sinclair method where some patients will take it about just an hour before they anticipate being in a high-risk situation. So some people feel that that's a helpful approach, but the evidence is really for the daily dose of the naltrexone or the monthly injection. It's contraindicated in someone who's on opioids because it could precipitate withdrawal in someone who's already having agonist effect on those new receptors. You do need baseline monitoring of liver function, and it's been shown to decrease craving. Basically, if someone is taking it and has a drink, then what it's been shown to do is help decrease the chances of that one drink turning into an extended relapse. Again, lots of evidence as supported by Cochrane review showing a decreased relapse to heavy drinking when compared to placebo. And then just to touch upon the combined study, this does come up a fair amount because this was really the largest clinical trial in the US at 11 sites in the US, and it basically looked at different combinations of placebo, acamprosate, naltrexone, all with medical counseling and the visit with the provider, and then with or without the cognitive behavioral sessions. And what it really showed was that that naltrexone alone, so within the context of the medical visit, and cognitive behavioral with placebo had the most substantial decrease. And so this was a good evidence that providers in like a primary care setting can prescribe this medication with good effect. And then there's some potential benefit, but no FDA approval for other medications. There's a few more too that aren't listed here, but for instance, Gabapentin, Topiramate, and Baclofen have had some small studies showing some effect, and anecdotally there's been some. The Gabapentin, which was initially approved for treatment of epilepsy, neuropathy, has had some randomized controlled trials showing a higher rate of abstinence when compared to placebo. Topiramate, which was also initially approved for treatment of seizure disorder and preventing migraines, also has a potential weight loss aid in combination with phentermine, has some randomized controlled trials showing less frequency of binge drinking and more days abstinent when compared with placebo. Baclofen as well. This was also approved for treatment of other neurologic conditions, so spasticity associated with neurologic disorders, and meta-analysis have shown longer time to lapse of alcohol with Baclofen, but not association with other drinking outcomes such as a decrease of binge drinking. So I'm sorry, I'm kind of moving quickly here because I want to try to wrap up by 12:30. The current APA guidelines are for naltrexone and acamprosate being recommended as first-line treatment for moderate to severe alcohol use disorder, and then they suggest the use of topiramate and gabapentin in patients after trying one of these first-line agents. And they do not recommend disulfiram as first-line treatment. So how to decide which medication to take? So again, for our patient, really any patient that is coming in seeking your help, we want to consider coexisting medical comorbidities. What were their prior experiences with treatment? What's their ability to take medication at certain frequencies? For instance, injectable, long-acting, but naltrexone may be preferable for some folks. And considering their psychiatric comorbidities, because oftentimes if we're not treating their depression and we're just treating the alcohol use disorder, it may not have as good of an outcome. For instance, there was a trial of 170 patients showing that there was higher rate of abstinence with naltrexone and sertraline, and these were people who had comorbid depression than with either alone. And then just to touch upon, I'd like to give this more weight than time allows, I think, but examples of therapy that have been show strong evidence for treatment of alcohol use disorder. So brief interventions, motivational enhancement therapy, cognitive behavioral therapy, family therapy, and then we'll touch briefly upon 12-step intervention. So brief intervention has a lot of the meta-analysis has been studied a lot of 34 studies, showed a decrease in the amount of alcohol for those patients who experienced the brief intervention as opposed to those who had none. But it did not show much difference on the frequency of drinking or their binge drinking patterns. So brief opportunistic interventions are, again, have a lot of evidence of their effect in the primary care settings, 5 to 30 minutes. They're not really meant as much for those who've already developed alcohol use disorder, so much as those who, it's geared at decreasing those who have a pattern of risky drinking. These feature include feedback, giving a menu of options, showing empathy, and self-efficacy. They typically have been shown to lead to about a third reduction in heavy drinking, and they have a significant effect that's been shown to last for up to 2 years. MI, again, is our Rolling with Resistance Identifying Change talk. Many studies have shown benefit for MI in treatment of alcohol use disorder. It's found to be most effective in the first 3 months and with younger populations who tend to have less clinical dependence on alcohol, and it can be offered as standalone treatment or in combination. CBT, this is working with patients to identify and modify thought processes that may lead to relapse. Helps prevent a lapse, therefore, from becoming a full-blown relapse, and there is a wide range of evidence supporting its efficacy. 12-step facilitation has more a goal of abstinence and involves individuals recognizing the harm of addiction, admitting their powerlessness over it, and typically involves recovery associated with a higher power. It has not had as much evidence to show efficacy as a standalone intervention as other modalities of therapy, however. And then just to close our case today, I want to respect Amy's time for her presentation. So after obtaining baseline renal function tests, you and your patient decide to start Acamprosate. We're starting at 333 milligrams 3 times a day, and then she increases to the target dose. And then you encourage her to keep taking her medication, to meet with the psychologist for CBT. And at her 1-month follow-up, she reports that she had a lapse of 1 drink. However, it didn't lead to a relapse, which was that is part of the goal of the medication. Her blood pressure is also normalized. She also screened positive for depression and agreed with incorporating sertraline into her regimen, which she reports has also helped improve her mood. Excuse me. So in summary, please screen youth and adults on a routine basis using the validated screening tools, and feel comfortable diagnosing risky drinking, recognizing risky drinking and diagnosing alcohol use disorder so that we can promptly offer treatment. It is one of the most undertreated health conditions in the US. It's important to be able to assess withdrawal and recognize if a patient needs inpatient versus outpatient management, and then also to be comfortable with the different treatment modalities involving both medication and therapy. So we can open it up maybe to a couple quick questions, and then